So we waiting maybe 2 or 3 more minutes and then we will start ค่ะก็พูดไปเรื่อยๆก่อนแล้วกันนะคะระหว่างรอเอกสารประกอบการบรรยายนี้อยู่ที่อีเมลนะคะเมื่อเช้าส่งไปให้ค่ะก็ดาวน์โหลดได้นะคะไฟล์ค่อนข้างใหญ่ก็เลยต้องส่งเป็นไดรฟ์ไฟล์นะคะก็อยู่ในไดรฟ์นะคะดาวน์โหลดได้ถ้าใครยังไม่ได้เดี๋ยวตอนที่จบเซสชันอีกทีก็ส่งให้อีกทีได้นะคะต้องมาสัก30แล้วบอกที่เต็มที so let's see ดูบรรยากาศในห้องออนไซต์ก่อนเราเอาวิดีโอมาได้ไหมนะ จะเห็นไหมนะDr. Enzo is here Yay. and other people cannot มองไม่เห็นนะคะกล้องเรามีการจับภาพได้แค่นิดเดียว ก็มีอาจารย์อมรรัตน์มาอยู่นี่ด้วยค่ะขอบคุณอาจารย์มากอาจารย์มาถึงนี่เลยค่ะอาจารย์มาจากมอ.เลยนะคะก็น่าจะสักกี่คนแล้วนะคะตอนนี้17ค่ะก็รออีกสักนาที2 นาทีแล้วกันนะคะก็ระหว่างรอจริงๆก็ขออนุญาตพูดไปก่อนนะคะพูดไปก่อนอันนี้เราพูดภาษาไทยปนภาษาอังกฤษนะคะแต่เซสชันของ Enzo ดร. Enzo ก็จะเป็นภาษาอังกฤษนะคะก็บอกแล้วค่ะว่าจะพยายามพูดช้านะคะแต่ว่ามีส่วนไหนที่ไม่เข้าใจนะคะหรือว่าอยากซักถามเราทิ้งครึ่งชั่วโมงสุดท้ายให้ซักถามกันเลยนะคะต้องขอบคุณนะคะการจัดเซสชันนี้เนี่ยทำเพื่อให้ศูนย์ที่เป็นศูนย์ตรวจนะคะได้เข้าใจหรือว่ามีความรู้เพิ่มขึ้นนะคะแล้วก็จะได้ไปด้วยกันนะคะ I already told Enzo about we have 10 national newborn screening centers right now actually start the expanded newborn screening maybe just only 4 or 5 center not all ค่ะก็ it's the lab center and we also have 7 rare disease centers that we call so เรารู้จักกันว่าเรามี7ศูนย์โรคหายากที่เป็นศูนย์ของหมอ geneticist นะคะที่รักษาโรคกลุ่มพันธุกรรมเมตาบอลิกนะคะแต่ว่าศูนย์ที่เป็นหน่วยบริการตรวจเนี่ยมี10ศูนย์นะคะแล้วก็ cover เขตสุขภาพคือ13เขตสุขภาพของประเทศไทยนะคะเราก็แบ่งกันไปเรียบร้อยแล้วคิดว่าทุกท่านที่เข้ามาในเซสชันนี้น่าจะทราบพื้นฐานของการบริการของสาธารณสุขของเรานะคะเรื่อง newborn screening นะคะอันนี้ก็เป็นตารางนะคะว่าit's Thai sorry Enzo that's okay right so we have like 10 newborn screening centers that we are responsible for particular region so we start some but some not start yet on the process and we think that we need to come together and get all come together ค่ะก็คิดว่าทุกท่านก็จะมาจากศูนย์ต่างๆเหล่านี้นะคะที่มาช่วยกันทำเรื่องของ newborn screening นะคะก็ตัวเองก็คิดว่าการทั้งการทำ lab รวมถึงการแปลผลรวมถึงการติดตามคนไข้กลับมาค่ะ3ส่วนเนี่ยมันต้องครบถ้าไม่ครบเราอาจจะพูดยากว่าคือ newborn screening ที่ดีนะคะเพราะฉะนั้นก็ต้องทำงานไปด้วยกันนะคะก็ตอนนี้เนี่ยอันนี้เราแชร์ได้นะคะเรื่อง education สำหรับคุณพ่อคุณแม่นะคะของแต่ละศูนย์สามารถเอาวิดีโออันนี้ที่เราทำไปแชร์ได้เลยนะคะเราไม่ได้จำกัดก็การที่พ่อแม่เข้าใจหรือว่ารู้ว่าลูกทำอะไรเนี่ยเวลาผล positive ขึ้นมาเขาจะทราบอะค่ะแล้วก็ให้ความร่วมมือกับเราได้ดีว่าจะตามมาเพื่ออะไรนะหรือว่ายังไม่ต้องตื่นเต้นเนาะใช่หรือยังไม่ใช่ก็เป็นไปได้เพราะนั้นอันนี้เป็น YouTube ที่เราทำแอนิเมชันมานะคะก็มีแค่ 3-4 นาทีค่ะก็เอาไปเผยแพร่ต่อได้นะคะ Okay right now is 24 people online so it's like a half ก็ประมาณครึ่งหนึ่งนะคะที่ลงทะเบียนมา ก็เข้ากันมาแล้วก็เราก็เกริ่นประมาณนี้นะคะก็วันนี้เนี่ยเนื่องจากมีเวลาเต็มกันสักถึง3:30นะคะก็พูดช่วงต้นแค่สัก10 นาทีนะคะแล้วเดี๋ยวเราจะให้ดร. เอนโซนะคะพูดคุยนะคะแชร์ประสบการณ์เต็ม2 ชั่วโมงนะคะให้ฟังนะคะก็ตาราง overview ก็ประมาณนี้นะคะประมาณชั่วโมงแรกจะพูดเรื่อง overview newborn screening สำหรับ inborn error of metabolism นะคะหรือบางทีเราเรียก inborn metabolic disorder ก็ได้นะคะเป็นกลุ่มโรคเดียวกันแล้วก็เราจะ set up newborn screening center เนี่ยพวกเราก็อาจจะเป็นจุดเริ่มต้นเกือบกันทั้งหมดนะคะใครทำแล้วทำไม่แล้วก็ถือว่าทุกคนเป็นจุดเริ่มต้นเหมือนกันแล้ว quality assurance เราจะรู้ได้ยังไงนะคะว่าเรางานเราคุณภาพนะคะสำหรับ newborn screening lab นะคะก็บอกดร. เอนโซแล้วว่าจะมาแชร์ให้ฟังนะคะส่วนชั่วโมงที่2ก็จะเป็นเรื่องของการ interpretation นะคะซึ่งก็โดยส่วนตัวถึงแม้เราจะเรียนมาด้านนี้เราก็รู้สึกว่ามัน challenge มากนะคะแล้วมันก็ใช้ประสบการณ์แล้วก็มีอะไรที่เราต้องเรียนรู้นะคะเรื่อง interpretation แต่ว่าจุดเริ่มต้นจริงๆต้องพอเข้าใจ pathway มันก่อนแล้วเราจะสนุกกับการแปลผลนะคะแล้วก็จะมี sharing challenging case ให้ดูด้วยนะคะแล้วก็ครึ่งชั่วโมงสุดท้ายเลยค่ะก็จะเป็นลักษณะ question and answer นะคะตอนนี้ถ้าเว็บ X อะค่ะมันจะมีช่องแชทนะคะถ้าอยู่ข้างล่างสามารถเขียนคำถามเป็นภาษาไทยได้นะคะแล้วก็หรือจะพูดคุยกันเป็นภาษาอังกฤษก็ได้นะคะแต่ว่าถ้าเสียงไม่ค่อยชัดพิมพ์แชทมาก็ได้นะคะเดี๋ยวตัวเองจะอ่านมาให้นะคะก็คิดว่าน่าจะใกล้ๆได้เวลาแล้วขอ let me introduce Dr. Enzo Ranieri วันนี้เราแบบ subtitle นิดนึงภาษาไทยภาษาอังกฤษเรางงไปหมดแล้วSo we are great pleasure that you come here to be with us in Thailand and give a talk today. So Dr. Enzo Ranieri, he is the head of biochemical genetics and molecular pathology in SA pathology. That is the South Australian, right? Yeah, and the lab is in Adelaide. So Adelaide is there.In the South Australia, and he also a head of South Australian Neonatal Screening Center and Antenatal Screening and the Metabolic Laboratory Department of Biochemical Genetics, and he also a Directorate of Genetics and Molecular Pathology of South Australian Pathology at the Women and Children's Hospital, Adelaide.In Australia. So please welcome Dr. Enzo. Otherwise, it's like your profile. So we're gonna start English version. Thank you. Please.
Thank you very much, Jamie, for that welcoming address and introduction to me. And it's been an absolute pleasure to have had the opportunity of being invited to come here to your department and provide you with the knowledge that we've acquired over the last 30 years. Now, my presentation is going to be quite a general one. I've provided you with a PDF of the presentation such that you're able to keep up in the event that there is a video malfunction. So my talk is going to be the requirements of newborn screening and focusing on the expansion of newborn screening and focusing on the introduction and the usage of tandem mass spectrometry to identify a much greater group of inborn errors of metabolism. So the topics I'm going to cover is give you an insight into the aims of newborn screening, the type of disorders that we screen for, and how to set up a uniform panel for screening, and then give you the concept, the very required concept of understanding what is a discrete test as opposed to profiling. And you need to understand the metabolic pathways in order to be able to interpret the results from mass spectrometry. And then I'm going to talk about how the newborn screening program can be expanded using what we refer to now as metabolomics, the use of tandem mass spectrometry, and then just touch on next-gen sequencing, and then I will give you vignettes of case presentations of real cases that we've had. Now, the tenet or the rule in newborn screening is that it's widely accepted that newborn screening is an essential, preventative public health program. There is no question about that. And the aim of screening is to provide a screening program of neonates on a population base, to which then you are able to identify babies at increased risk for diseases that are not easily clinically identified in the newborn period, and where the diagnosis and early initiation of treatment prevents delays or reduces the consequences of that specific inborn error of metabolism. Such the outcome is to reduce the disability and serious disease. And our motto within our department, never not treat a treatable disorder. Now, just a bit of geography. Australia is a very large country, nothing much in the middle. Most of the cities lie around the coast. There are 5 screening centres, as you can see from those red dots, centred in each of the major cities, and they're attached to paediatric teaching hospitals, where they provide the screening, the follow-up metabolic diagnosis, and the treatment of all patients identified by inborn errors of metabolism. What I've also identified here is the year in which expanded newborn screening started. So Sydney in 98, we only a few months later, and then the other states much later. And so this has afforded an opportunity for us to see the benefits of and the impact of the expansion of newborn screening. So I will give you the data of that at the end of the presentation. This is a picture of my hospital, the Women's and Children's Hospital. It's a tertiary paediatric ONG hospital that serves a population of about 1.8 million babies. And it's a very tranquil, quiet, nice place, and I think Jamie will recall fondly of spending some time with us in the department. Can't go without saying and making some reference to the individual, Robert Guthrie, who devised this method of screening. There is now the International Newborn Screening Day, which is featured on his birthday on an annual basis. In South Australia, some of the milestones I can identify here, we started back in 1966, and you can see as technology has advanced and treatment has advanced, we've introduced the screening of additional disorders. The last one on that list is now the introduction of the screening for spinal muscular atrophy and severe combined immunodeficiency, which will commence in 2023. Overall, we've picked up over 1,200 babies, and the collective incidence of these disorders is about 1 in 800 babies. Significant. These are our cards, pretty well standard. You can see that on the end of our card that there is a screening for hearing disorders, where in 2002 we added the screening for hearing disorders with an auditory test of the baby, and that information is recorded on this card, and we are just simply the conduit in which that information is then fed to the audiologist. We provide education material, extremely important. Important in that our midwives are the ones who collect the sample from the baby. We have to provide pamphlets, screening tests for your new baby, to the parents, so that the parents understand the tests that are going to be performed on their baby and what may happen in the event that we identify something at increased risk. We provide DVD information to the midwives. The midwives are able then to look at the video and thereby present the same consistent information to the parents. Midwives come in and out of practice, so this is an ability for them to upskill or update their training. Now, the introduction of expanded screening in South Australia, or basically in Australia, for us, it's part of a site-specific funding to provide specialised screening and diagnostic service. It's a site-specific activity. It's evidence-based medicine and cost benefit analysis is undertaken before we can introduce a new screening for a new condition. We usually undertake feasibility studies to see what would be the cost for the state government. This is a public sector funded program, and we must ensure that we spend the public purse money in an appropriate manner. And screening does not stand alone. It must be integrated with a metabolic laboratory that provides the diagnostic testing and a metabolic clinic that treats the babies. So that's a complete circle. We have education and training not only for the pediatricians and neonatologists and midwives and dietitians, but for the genetic counsellors and the social workers. And as I've described already, we have pamphlet information for the parents so that they understand the sorts of tests that are being performed on their baby. In Australia, there's a national policy on newborn screening. It is run through the federal government, through the capital of Canberra, where there is a committee, that's standing committee, that determines and makes recommendations to each of the state health departments in regards to what is recommended for screening and not. And this is a policy-driven committee whereby all babies in Australia have equal and equitable screening. Now, these committees are made up of a very diverse group. They're not a select group, very diverse, so that there is well-opinionated information that goes towards the recommendation. We even have an individual from the public as a consumer to provide information in regards to what is considered an appropriate thing to screen for or not. Now, there's the criteria for newborn screening in Australia's policy statement on newborn screening. We work with the Human Genetic Society of Australasia and the Division of Pediatrics of the Royal College of Pathologists, such that we are providing the benefits to the individual for early diagnosis, and that there is financial support and costs to provide the screening program, and that there is a reliable screening test suitable for newborn screening, and it must satisfy the operational needs for the follow-up of diagnostic testing, counselling, treatment for all patients, all babies identified by the test. Now, I've mentioned to you that newborn screening is an integrated system. It does not stand alone. It's made up of the sample collection. Without the proper sample collection, the testing that is done on that will be of poor quality. You need appropriate laboratory tests. You need analytical procedures and techniques. And most importantly, you need quality control within the laboratory and quality assurance, which comes external from your laboratory, to monitor the performance of your laboratory. You need follow-up information. That is, the babies that you have identified at increased risk from screening are then followed up and assured that we either collect another sample where it's required or that they are followed up by the metabolic clinic. We have the need for audit trails. We want to know how many babies are being screened, how many samples were of poor quality and needed recollection, how many babies had an interim or a provisional increased risk result, that is false positives. How many of those false positives indeed had an inborn error of metabolism? The diagnosis, you have the requirement upon identifying from newborn screening a baby that has a provisional increased risk. They will need to be recalled back by the metabolic clinic. They'll need counselling, genetic counselling. They also need urine and blood and maybe CSF if required to confirm or exclude that provisional increased result. You need the clinical management, the treatment and continuous monitoring of the patient, and then evaluation of the outcome. And then at the end is the continuous education and training. So I hope I've instilled in you that newborn screening is an integrated, it does not sit on its own. Now, newborn screening must have set core conditions. You must decide within your own organisation, within your own screening program, what disorders you're going to be screening for and the reasons behind it. A screening laboratory should do around about 20,000 samples a year in order to be able to do all the surveillance as required. They should be able to undertake the high sensitivity and specificity. You need to have acceptable false positive and acceptable false negatives. You're going to have both because it's a screening test. A screening test will not pick up all. It's essential that the program must have reliable reagents and consumables in the kits, and that they are registered for specific use for dried blood spots. You can't use a method that's being developed for plasma or serum and expect that to be used for a blood spot. Newborn screening laboratories must undergo accreditation. And they must participate in quality assurance program, which I'll refer to later. And then it must monitor its performance, not only at a national level, but at an international level. So what's so important about early diagnosis? Inborn errors of metabolism are often life-threatening. Treatments exist for many of the inborn errors of metabolism. There is a window of opportunity that enables that period to maximize the outcome, because when you identify them in the first few days of life, these inborn errors of metabolism are invariably asymptomatic. And so the outcome between pre-symptomatic versus symptomatic treatment is significantly different. I'm sure Jamie and her team would attest to the fact that it's easier to treat a baby that is asymptomatic and not in ICU or a PICU. There is a preferred path of diagnosis is pre-symptomatic newborn screening. The main outcome of neonatal screening is to decrease mortality and morbidity, reduce disability, prevent harm to the family members, prevents damage to the unborn child, and reproductive choice and quality of life, such that you reduce the disability and handicap in the child. So what are the really important questions for screening programs? These are, can we find the cases? That is your testing able to identify them when they're pre-symptomatic? Does the early diagnosis, when they're asymptomatic, do any good? Does it do any harm? Most importantly, from our funders, can we afford it? And just because we can screen for a condition doesn't mean that we should. So you need to be mindful that you want to adhere to those tenets regarding newborn screening. Newborn screening is now undergoing an enormous revolution. In this newborn period, we're able to identify disorders in the baby. And this has enabled us to do so because of the advances in techniques that makes now anything screenable. You can screen for almost anything because there are now no longer the limitations that there were in the past by instrumentation and advances in technology. We also must be very wary of the ethical and financial issues around neonatal screening that may be what's referred to as untreatable disorders. So you can see the impact of what you will have upon newborn screening when you're doing the collection when the baby is only 48 hours of age and provide a diagnosis or a treatment within the first 2 weeks of life. Advances of next-gen sequencing is going to have an enormous impact on newborn screening. This is just starting now. I'll touch on it at the end of my talk. I cannot but refer to the Nobel laureate in 2002, Sidney Bremer, who in his acceptance speech said, progress in science depends on new techniques, new discoveries, new ideas, and probably in that order. This is certainly the case in newborn screening. Newborn screening has undergone a huge paradigm shift. The newborn screening techniques has now moved us from a discrete test to a profiling. And it's enabled us to expand newborn screening for the identification of a whole group of inborn errors of metabolism by the advances in technology using mass spectrometry. There is synergy, absolute synergy, between metabolomics and genomic techniques. They are now very much integrated, and in combination with clinical interpretive algorithm, the amount of information that is now delivered to you is huge, to the point where you need very clever interpretive algorithm to enable you to assimilate all that information that comes. So these two technological advances that have impacted newborn screening is what I refer into the category of biochemical genetics by the use of tandem mass spectrometry and the automation that goes with it. So it enables you to do thousands and thousands of samples to identify these inborn errors of metabolism. The other face of the coin is next-gen sequencing. And this is going to have a significant impact, as there are now many programs, and I believe one in Thailand as well, that's looking at next-gen sequencing as a means by which to describe your population. You can see that the future changing face of neonatal screening is the combination of those two technological advances. Just to date, by mass spectrometry and next-gen sequencing, we've expanded the disorders that we can screen, where in the past that was unable to be done. Spinal muscular atrophy is one recent one, where that is the first test in which DNA testing is the first frontline testing modality. Automation is a must. If you're doing 20,000 samples, you need systems that enable you to punch these things. That's a genetic screening processor that enables thousands of samples to be processed via immunoassays. And furthermore, mass spectrometry, these are the ones in my department. The ones that you got on the top left-hand corner are old machines. They've already been updated. We've got a QSite 220, and we've got the laboratories and facilities to process the samples. Now, our mass spectrometry facility has moved with the ages. We started this in December 1998. And that individual there was our first organic chemist, David Johnson, who is retired many years ago. Our first instrument was used to develop the methods for screening for these inborn errors of metabolism. And as time gone along, we've been able to acquire new, updated, more sensitive, more high throughput machines, and being able, of all manufacturing types, that has enabled us to continue the expansion of our program. And the use of mass spectrometry now is an integral part of our biochemical genetics department. It's equivalent to a spectrophotometer. We can't do without them at the moment. And this is our QSite 220, and this is our first metabolomics instrument. It's a QTOF machine, and we've got now 2 of them to proceed with the expansion of newborn screening for inborn error metabolism by approach of metabolomics. I've mentioned to you that there has been a massive paradigm shift. Newborn screening techniques have moved from what we refer to as discrete compared to profiling, and I'll give you a description. A discrete test, you take one spot, you measure one compound, you measure one disorder. So if you want to do many disorders, you need many spots from many analytical methods. An example of a discrete test is the measurement of a blood spot TSH using a fluorescent immunoassay to identify congenital hypothyroidism. And so what you have in a discrete test is the green, a normal population distribution, and you have a cutoff assigned to which then anything above that cutoff you would follow up. Now, profiling testing requires you to have a single 3 millimeter spot to which you measure multiple compounds for multiple disorders. And so the technique that enables you to do that is mass spectrometry. And an example of the multiple compounds are amino acids and acyl carnitines. And this tandem mass spectrometry is an extremely powerful analytical tool. It simultaneously is able to measure multiple analytes, and in this case, amino acids and acyl carnitines. By the identification of these amino acids and acyl carnitines, you're able to identify over 30 different types of inborn errors of metabolism. They can be done simultaneously by the measurement of both amino acids and acyl carnitine, and most importantly, through high throughput. It does thousands of samples. Now, these inborn errors of metabolism that I've just described, of which now we're able to identify more than 30. These are biochemical disorders due to a genetically determined specific quantitative or qualitative defect in a protein molecule or its cofactor or a carrier protein. These inborn errors of metabolism are considered monogenic disorders, but monogenic disorders, complex traits. There's a lot of grey area between it. Not all monogenic disorders behave in the same manner. But these inborn errors of metabolism, being able to be identified by tandem mass spectrometry, reside in these three classifications known as fatty acid oxidation defects, amino acidureas, and organic acidureas. Now, if anybody is interested in the molecular basis of inherited disorders, this online enables you to identify almost all of those known inborn errors of metabolism, and these are indeed a heterogeneous group. Decline, okay, sorry. Large heterogeneous group, they're each caused by a genetic defect or mutation, resulting in a defective or absence of an enzyme cofactor, an enzyme or its cofactor or a transporter protein in a biochemical pathway, which they are critical to normal cellular function, growth, and development. Okay, and sorry. And so there are other well-known textbooks by Nenad Blau, A Physician's Guide to the Diagnosis, Treatment, and Follow-up of Inherited Metabolic Disorders. And we were asked to write the first chapter in this revised second edition, where we provided the chapter on newborn screening for inborn errors of metabolism with my previous genetic pathologist, Janice Fletcher, who retired 2 or 3 years ago, and a colleague out of Zurich, Ralph Fingerhorn. So you can see that this textbook crosses all inborn errors of metabolism across each of their respective disorders. Now, these disorders, some of them are extremely rare, some are more common than others, but the takeaway message is collectively they are probably occurring in a population of 1 in 280 babies born. And it represents about, this is a US publication, represents about 10% of pediatric admissions and roughly about 20% of infant mortality. And there are over 6,000, maybe more closer to 7,000 genetic disorders affecting a vast number of individuals. Whilst any individuals, like the one at the far tail is Tay-Sachs disease compared to cystic fibrosis, whilst they're maybe very rare, collectively they represent a significant proportion. In order to interpret these inborn errors of metabolism, you really need to know biochemical genetics 101. You need to understand pathways and how pathways work. These pathways are driven by a single enzyme cofactor or a transporter protein, but in essence what is occurring in very simplistic cartoon fashion is as the substrate is converted to a product, there's an enzyme and a requirement for its cofactor. If there's a deficiency in that enzyme or its cofactor, or it revolves around a transporter protein, you get a buildup of S, which is usually toxic to the cell. You're deprived of the substrate P, but the cell has the ability to have side reactions, and you can convert it to other side reactions, which themselves may be toxic. An example of that is succinyl acetone in tyrosinemia type 1. We're just starting to touch the surface of all the metabolites that we can measure within the vast expanse of biochemical pathways. With the ensuing methods of metabolomics, we're getting very close, or getting closer to being able to take a metabolic snapshot of the cell. And then we can cross right across these metabolites that impact other disorders, such as peroxisomal disorders, 1-adenoacetate in the GAMP disorders, glycogen storage, lysosomal storage disorders, disorders of purines and pyrimidines. So you can see how this technology will in the future impact to the point where we will be able to screen for a vast number of disorders. How do these inborn errors of metabolism present clinically? Well, some can have acute symptoms in the neonatal period, like pyruvate carboxylase, the late onset or acute recurrence attacks, coma, ataxia, vomiting, acidosis, lethargy. They can be chronic or progressive disorders through digestive or neurological seizures or muscular hypertonia. So these are some of the clinical presentations that are associated with an inborn error metabolism. They can have specific or permanent organ symptoms such as hepatosplenomegaly, cardiomyopathies, and so forth. And the classification of these disorders can be done in basically these three. Disorders involving complex molecules, such as the lysosomal storage disorders, mucopolysaccharidosis, which is glycosaminoglycans. Disorders that give rise to intoxication, such as some of the organic acidureas or ornithine transcarbamylase in hyperammonemia. Disorders involving energy metabolism, such as the TCA intermediates or the formation of acetyl-CoA in the fatty acid oxidation defects. These are rare but treatable entities. Whilst I said that they're individually rare, collectively they're very significant. Now, if you were to assess the prevalence by clinical presentation, you're always underdiagnosed. And the numbers in a good clinical setting is 5 to 10 per 100,000. Not readily identified clinically. But those detected by newborn screening is almost 4 to 5 times more per 100,000. Collectively, they exist about 1 in 3,000. And so the 5 major types of metabolic distresses that are seen, and 80% of these inborn error metabolism will fit within these categories. There are predominant ketosis, maple syrup urine disease, predominant ketoacidosis with hyperammonemia, such as the organic aciduria, isovaleric acidemia, propionic acidemia. Predominant lactic acidosis with neurological distress and energy deficiency, mitochondrial disorders. Neurological intoxication, such as that which is brought about by hyperammonemia, and OTC in the urea cycle is one example. And then neurological deterioration without ketosis or hyperammonemia are those with the respiratory chain or the fatty acid oxidation defects. Just to highlight why it's imperative to be able to identify this within the early newborn period. This is a publication by Durand in Pediatrics in 1989. This gives you the urea cycle defect ornithine transcarbamylase in red. Now, in that condition, results in hyperammonemia. The graph on the right is the consequences of persistent hyperammonemia and a coma. Not very good for a baby that's been under hyperammonemia for a period of a week, where you can see the consequences on that individual's outcome in IQ. Hence the need to identify them early so that they can be treated to reduce the hyperammonemia and thereby salvage some of the neurological function. Identifying inborn errors of metabolism in the newborn period. I'm going to go through 2 ways of doing this. What we used to do before, what we can do now. The before was selected by clinical presentation, and then I'm going to talk to you about how we detect them with newborn screening. This is a real example. This request form from CDU, Child Development Unit, from a pediatrician who saw a 2-year-old child who's put down there on the clinical notes, mild intellectual disability. Such a request form would come with plasma and urine, and it would go through urine organic acid, plasma amino acids, to see whether there is an inborn error of metabolism that may be the reasons behind this child having this mild intellectual disability. With the introduction of tandem mass spectrometry, that's changed everything, considerably changed everything, in that now mass spectrometry will be used on all babies, to which a very small percentage, less than 0.2% of that population, will then proceed to confirm or exclude what may be an inborn error metabolism. You're still using the classical techniques of urine organic acids, plasma amino acids to confirm or exclude, but a very small percentage is now being shuttled through to that. And now we've even changed that even further by using mass spectrometry to do the urine organic acids that can do it much quickly and much more efficiently than the existing classical methods of GCFID. And these machines are quite capable of doing it. Urine organic acids can be done on these machines, and you don't need a super duper powerful machine in order to provide that service. By the way, that baby was identified as having malonic aciduria. And we can screen that now using one of the acetol carnitines, malonyl carnitine. Now, newborn screening can be undertaken in what we call two-tier screening strategy. Technological advances enable us a high throughput. It can be performed efficiently, effectively, and timely at a reasonable cost. There are added complications that you also identified, unfortunately, conditions that are benign. You don't want those. Late onset disease, you don't want those either. You can identify pseudodeficiencies in which they may have low enzyme activity, but yet will not show any phenotypic consequences. And then available therapies. No point identifying a baby for which you then can't find the treatment to correct the problem. And so we developed these two-tier strategies, where in the first tier, we identify a baby at increased risk from the blood spot measurement of the amino acids acetol carnitine, and then on that same blood spot, we can use additional mass spectrometry techniques or the next-gen sequencing to confirm or exclude before you recall the baby. And that works really quite well. So when's the best time to do all of this? I've told you what I've told you now, but at what time? When is the best time to screen? A sample collected at or near 48 hours of age is the best, because this gives and provides us a unique opportunity to get the baby's adapting to ex utero. It's doing normal catabolism. It's doing normal catabolism. It will be converting and utilizing its brown fat for ketogenesis through acetol carnitines to generate energy. That baby needs a lot of energy and it can't necessarily get it externally. In that period, a sample collected at or near 48 hours, you reduce the risk of missing a test because the analytes that you're measuring to identify that are maximized. There's very little background problems, and usually there's no interferences from drugs other than the preterm low birth weight infants, but they've already declared themselves because they're low birth weight and preterm. And so in that period, when the sample is collected at or near 48 hours, you normally would find them pre-symptomatically. So early treatment, better outcome. Right, this is a paper from 1965, well before your time, Jamie. And this paper talks about energy sources in a newborn. I found this an interesting article where it says that hence he must use his own reserves, particularly lipids and carbohydrates, and in some cases also proteins to generate its energy. And this is a simplistic view of what a baby, infant, and adult would do in terms of energy requirements. In the neonate, within 2 hours, the baby's used all its glucose, hence a lot of hyperglycemia in babies. Within the next 4 hours, it's used all its glycogen. It's then starting to use its gluconeogenic amino acids, of which there are quite a few. And then by 8 hours, that baby is beta oxidizing. It will be using its brown fats to generate acetyl-CoA from the breakdown of the C16 and C18 in its brown fat. So you can see that any inborn error of metabolism is going to present itself within that first 8 hours after birth. An adult, you can fast for 3 days before you even think about beta oxidizing. And here is a cartoon of why we consider that period at 48 hours to be optimal. This is an example of PKU, phenylketonuria. The absence of the enzyme phenylalanine hydroxylase elevates the level of phenylalanine. So in a normal baby, it goes up, then comes down. That's normal. But in a baby that has phenylketonuria, an absence of the enzyme phenylalanine hydroxylase, that phenylalanine begins to rise really rapidly and the level of tyrosine begins to reduce. So you can see how this period is an optimal. When we look at a fatty acid oxidation defect, it's a little bit more different. Again, that period of 48 hours is the optimal time. This is a baby that is a profile for medium chain acyl-CoA dehydrogenase deficiency. The marker metabolite for this condition is the C8 carnitine. As you can see, soon after birth, this baby is wanting to produce acetyl-CoA from its fatty acid. it gets stuck because it can't go past the C8 and C10, and so C8 begins to elevate. Now, if it gets past this critical period, it will begin to reduce away. Then some episodic event, immunization, an infection, would make that rise again. So you can see that if the baby gets past this point and doesn't die, it could consequently have and suffer a later episode. So again, the window of opportunity is at or near 48 hours of age. Now I'm going to bring you across the concept of a primary and a secondary marker. So this is beginning to the concept of interpretation. We refer to as a primary analyte as either an amino acid or an acylcarnitine. There's about 36 acylcarnitines, about 16 amino acids that we use to establish presumptive positive. The secondary markers are what we refer to as ratios. These ratios describe the metabolic pathway, and they're used in conjunction with the primary analytes to make a decision. These secondary markers, when they're elevated, are unimportant. They have no impact because they can be elevated because they're ratios. And some elevated ratios in the absence of a respective analyte are unimportant. There are some exceptions to the rule, but by and large, the primary analyte must be elevated in addition to the secondary marker, which is a ratio. How do we measure these? Well, you can measure that. We've been using an in-house method to measure these amino acids and acylcarnitines. But now, and this requires a specialist organic chemist and mass spectrometrist to maintain these. There are now available many kits, and we're likely to be moving from our in-house homebrew to a commercial kit, because a commercial kit has FDA approval and for us TGA approval. And these kits are able to be used and they're certified, taking away the need to concern yourself with trying to do these in-house. We've been doing it for a better part of 30 years, and it's become very difficult as we include more metabolites. The use of in-house stable isotopes and kits becomes more difficult, and we have to ensure that they meet in vitro device certification. Whether it's in-house or kit, the fundamental way mass spectrometry works to measure these is a technique known as stable isotope dilution mass spectrometry. These usual stable isotopes of hydrogen, carbon, and nitrogen are incorporated into a molecule that moves them away in mass, in atomic mass units, from the thing you want to measure. As an example, I've got here, for the measurement of phenylalanine. This is from a 3 millimeter blood spot. So what we have is the measurement of phenylalanine, who has a mass of 166.1. It has an intensity of this height. You've mixed within the blood spot here with the stable isotope, the internal stable isotope of phenylalanine. In this case, 6 of the carbons are replaced by the carbon-13, making it 6 atomic mass units away from what you're measuring. So this is what we add to the blood spot, such that we can measure the phenylalanine from that blood spot. And this up here is the way in which you do it. The blood spot is in a solution. These yellow stars are just representing all the stable isotopes that are added. We want, in quantitating the amount of phenylalanine, is the intensity of the phenylalanine, which comes from the blood spot, divided by the intensity of the stable isotope in which your stable isotope dilution, multiplied by the volume of blood, which is about 3.2 microliters, and then you can calculate the concentration of phenylalanine in micromoles per liter of whole blood. And this is what happens. Mass spectrometry generates in 90 seconds, and this is from our data. You can see up here, we've got the measurement of phenylalanine, tyrosine, methionine, and so forth. And it continues on to all the acylcarnitines. There are over 80 things that we measure, and here are each patient. The difficulty now is to be able to interpret all of this. And the fundamental requirement is the need to generate reference intervals using particular statistical methods, for which Jamie is now proficient and expert, and the understanding of biochemical genetics pathways, because they have to be mapped. And so I'm going to go through this process so that you understand what is required to do these interpretations. You remember the TSH, discrete test, can't use that. That's not going to work. If you try to use this approach, you will fail miserably. The difficulty we have is that in the ideal world, you would have a green normal population, you would have a red abnormal population, and then you would pick your false positive and false negative in order to make your reference intervals to pick as many of the abnormals, true abnormals, from the false positives from those who do not have the disease. Classical Gaussian distribution. That's not the real world. This is more the real world, where you only really have a measure of the normal population, because these inborn errors of metabolism are rare and you don't have very, very many of them. So you need population distributions of the normal unaffected population in order to generate reference intervals that describes your normal population extremely well, to which then you would have sufficient evidence to say who has and who does not have the disease. And so you can use percentiles, because these are usually non-Gaussian. You can't use a mean and standard deviation. Or you can use something called multiples of the median, which I'll go through. And this is why, in doing the reference intervals, you have to be wary of the population you're using. Here is a population distribution on the top left of phenylalanine. Looks almost Gaussian. The one on the right is very skewed. It is C3, propanol carnitine, very non-Gaussian. This is one effect. The other effect below is the age at collection. You have to be mindful that a reference interval is done so that you only have babies who have a sample collected at 2 to 5 days. Here is an example of C16, which changes with age. Normal. The baby's using its brown fat in the first week of life. Very normal metabolism. Whereas other things like propanol carnitine that comes down from the breakdown of the branched chain amino acids, valine, leucine, and isoleucine, you can see it starts up really high because they're generating energy and they quiesce away. It's imperative. Two things that I want you to take away from this. One is that they're not normally Gaussian distributed, they can be non-Gaussian. So you need percentiles and multiples of the median to describe normal population. The other is it changes with age at collection. So do not use samples collected from 1 to 27 days because you've got a reference interval that will make no sense. I'm focusing on this because it's an extremely important concept. Here are 4 examples of population distribution, histograms, of phenylalanine, carnitine, citrulline, and glutarol carnitine. Now, we can plot that as a box plot, where that plot there represents the median value, the 50th centile. And then the box represents about 80% of the 90% of the population, and these are the tails. So what we can do is, for each of these 4, we can convert it to this. This is the same plot. You can see the yellow one for phenylalanine, and this is concentration. The thing that you note immediately, that if we're using the nominal value, the concentration, you get very, very low levels of C5DC, very high levels of carnitine and so forth. To interpret this is very difficult. There is a statistical procedure that you can do to convert things to multiples of the median. This is the same plot. For each of these, we convert these to what's called multiples of the median, and the multiple of the median is each and every value divided by the respective median of that population. Very simple calculation, very, very powerful. And what you, in essence, do is remove the scum. So here's an example of condition a distribution that looks quite skewed, and we can convert that by referencing to the 1st and 99th centile. We can generate and calculate the median, convert this population and multiples of the median, and then what you do is what I've shown you here for glutarol carnitine, C5DC. So the median value is 0.2 micromoles per liter of whole blood. I've now scaled it. The scale now becomes multiple of the median. Looks the same distribution, except I no longer have micromoles per liter, but I have multiples of the median down here on the scale. So what I can do with that is convert this into the right, making all things equal. Very, very powerful. Okay? And I'll show you how that's used in interpretation. So the clinical interpretation of mass spectral profiles requires you to generate reference intervals. Here you can see the top is phenylalanine, its median value is 47, its first centile is 30 and 77. And what we do is we're now looking at this in profiling. We're not a discrete test. So all these reference ranges here are then converted into the interpretation by profile. The first profile is for the identification of phenylketonuria and hyperphenylalemia. These two markers are what's required. For maple syrup urine disease, its profile is the measurement of valine, leucine, isoleucine, and these three ratios. Urea cycle defects and so forth. And this equally is applied to the acyl carnitines. So we're now looking at things in a profile. Here is medium-chain acyl-CoA dehydrogenase deficiency. In order to make the definitive diagnosis of the screening diagnosis of MCAD, we've got to measure C6, C8, C10, 10-1, and these two ratios in order to be confident that we're identifying MCAD. So this is not a discrete test anymore. And again, for VLCAD, very long-chain acyl-CoA dehydrogenase deficiency, you're measuring all of these in which to interpret. So this is our system for interpretation. All our reference intervals are in there, but I'm just going to do it in a cartoon fashion to show you the complexity. So this comes from our printout. And so in order to generate historical reference rates, you need about 3,000 samples to be confident of the first centile, the 99th centile, and then the batch that you're interpreting is usually a 200 or 300 or up to 500. So if we just take the example of phenylalanine, we have the phenylalanine concentration of the first centile is 30 micromoles per liter. The 99th is 77. The median value for phenylalanine in the newborn at 2 to 5 days of age is 47. Then you can have multiple median. 2.5 times 47 is 94. So we have the centiles first, 99, and we can have the multiples of the median in order to describe the normal population. Equally, for the acyl carnitines, and I'm just giving you the example of carnitine, the first centile is 12, the 99th centile is 57, the median is 25, and then you can see how the 2.5 and 62.5 is calculated. So we use those parameters in order to screen. Recalling that we're looking at this as a profile. And the profile enables us to have 1, 2, 3, or as many markers as required to identify the specific inborn error metabolism. I've highlighted here the single cell of phenylalanine for this patient, patient 1. The 56 and the background. The number is black, the background is white. It's normal because it's within the greater than the first centile and less than the 99th, unremarkable, normal. A baby that has an elevation of outside the reference interval above the 99th, the number will be red and the background will be red, okay? And then we can have intermediate, whatever color. Just as long as you're not colorblind, this works. Now, these metabolic pathways, as I've already mentioned, can have a number of metabolites that can be measured in a pathway. Remember that the cell has the ability for side reactions. Mass spectrometry can measure all of these. And as such, it becomes an extremely powerful tool to identify inborn errors of metabolism. So this is the concept. This concept of profiling we refer to as multi-parameter profiling. And it's based on two things: the ability to measure many compounds simultaneously and the understanding of biochemical pathways. Simple example 101. You've got a substrate, goes to a product. The enzyme's deficient, or its cofactor could be deficient. The substrate S goes up, the product goes down. So this is an example of PKU. We measure phenylalanine, we know the tyrosine goes down, and this ratio enables us to identify phenylketonuria. And so in all the pathways it could be, it's here, or it's cofactor, okay? It gets a little bit more complicated when there are sequential substrates, each substrate generating a product which then itself becomes the product. And so this is fatty acid oxidation, whereas the C18A, C16, C14, and so forth. But there are specific enzymes that deal with the respective chain of fatty acid. And it gets a bit more complicated. So if the defect lies here in the median chain, then D goes down, C goes up, B goes up, E goes down, F goes down. Right? So you are able to generate a profile specific for this inborn error of metabolism at this point in the pathway. And medium chain acyl-CoA, where C, D, and E are C6, C8, C10, and its respective ratios. And we know the defect is in here, medium chain, not anywhere else in the fatty acid oxidation pathway, because identifying the specific inborn error metabolism has all the consequences on treatment. The treatment for MCAD is simple, whereas the treatment for a baby with VLCAD is far more complex. And so these were the first two disorders that we picked up when we started. Here is phenylketonuria, and you can see how that clearly works, and MCAD here clearly works for MCAD. What are the weaknesses and limitations? Nothing is perfect. Some of the weaknesses and limitations of using this are that some analytes have low predictive value. Propanol carnitine, methylmalonyl carb, butyryl carnitine, tyrosine, glycine, glutamic acid. These have very low predictive values because you can have very high levels of C3 and it's normal. Some inborn errors of metabolism are not readily identified in the newborn period. They just don't have the elevation. For instance, tyrosinemia type 1, where you're only measuring tyrosine and not succinyl acetone, you are lucky to pick up 50% of the cases of tyrosinemia type 1. Ornithine transcarbamylase, again, you're lucky to pick up half of them because the analytes you're measuring are not always elevated or down. And then non-ketotic hyperglycemia, where you measure glycine and alanine, again, you're not picking them all up. You've got to be careful that if you've got an elevation, then the first thing to do is ask for a second sample. It doesn't work for some, in that the first sample is your most predictive. You get a repeat sample on a baby with VLCAD, that profile normalizes, but that baby still has VLCAD. And then some inborn errors are so rare, such as malonic aciduria, that they don't occur often, if at all, in your population. Other weaknesses and limitations. Identification of non-diseases. Benign. They're benign. They cause no phenotypic expression. 3-methylcrotonol-CoA carboxylase is one. And invariably, it's the mother who has the condition, not the baby. Short-chain acyl-CoA dehydrogenase. Some programs don't screen for that because it's benign and of no clinical consequences. These are unwanted because you have to counsel the parents for something that will never appear. And you undertake further expensive diagnostic testing for no purpose at all. Then there's some inborn errors of metabolism are unforgiving clinically. They present and declare themselves clinically so quickly that no screening program could identify. Pyruvate, carboxylase, some of the OTC, and definitely some of the mitochondrial disorders. For these, at least you've made a diagnosis, even though the babies clinically declare themselves. Other weaknesses and limitations. Identification of late onset. You don't want to detect these. For instance, arginine may present later in life. And then another weakness becomes your instrumentation. If your instrumentation goes down, you stop. You can't stop because babies are born every day. So you have to have in place contingency to overcome instrument failure. How do you evaluate these abnormal results? Well, I told you the mass spectrometry generates large data sets. It requires sophisticated data and demographic processing, and you need some sort of software management system to be able to distinguish these. You need to have reference intervals, population distribution. You need to generate cutoffs, which are generated from the first, 99th, 99.5th centile. You can use multiples of the median. These are all tools that you use. Now, the interpretive algorithm is not simply the selection of a cutoff. It's a upper limit of a normal population, that's all you've got, where you've got a clinically defined group that has accumulated disease. And it's balanced. You want to balance between limiting the recall. You don't want to recall too many babies. You don't want to have a recall rate of 1.5%. You want to reduce the false negative. You want to detect most of the babies when they're newborn. It's a balance, and in order to achieve that, you need to ensure that you're able to do this in an effective manner. I recommend you reading these articles. These are in Pediatrics, Genetics and Medicine. That was published quite a few years ago. The lead author on this is Rodney Howe, who was here on a visit, which puts up the recommended uniform screening panel that's used in the US and how they adjudicate what disorders are put in. The method developed by Piero Rinaldo has some standard statements in regards to a screening program and how effective you are. In their recommended uniform screening panel, of all the disorders that they screen for in the US, 78% of them are identified by mass spectrometry. Significant. And some of the performance targets, the detection rate in your population should be 1 in about 3,000. Your false positive rate would want to be less than 0.3, ideally 0.2, even better 0.1. You want to have a positive predictive value of at least 25%. Ours, in my department, it's 65%. That means for us, 3 babies that we recall for a diagnostic follow-up, 2 will have a confirmed disease, and a 3rd is likely to be a carrier. So just to highlight again, these are the sorts of things that you should aim for. So the complexity of biochemical pathways, there are secondary metabolic phenomena, genetic defects that cause a defect. One enzyme may have consequences to a number of other pathways. There are cofactors that are involved in multiple enzymes, and a single enzyme may catalyze more than one reaction. These generate complexities in the system. So I'm going to stop there for a few minutes because now I'm going into the vignettes of case examples. Okay?
Thank you very much for very extensive lecture. I think we learned a lot, and we have just maybe 5 minutes that we can have some rest, and then we come back in 5 minutes. And if anyone have any question ถ้ามีคำถามก็เขียนมาในแชทก็ได้นะคะ or anyone can ask Dr. Enzo from the first lecture. Anyone has any questions?มีคำถามไหมคะน่าจะยัง Yeah, I think that we all have know what is the newborn screening come from and what is the quality that we need to concern, and also the interpretation is not the discrete, it's like the profile, right? So I don't think that I have any question for now. Anyone write down in a chat ค่ะมีแชทใครเขียนไหมคะยังค่ะ
Am I converting you?
I have one question. Maybe you can explain. You said about recall rate, false positive rate that we need to concern, right? So can you explain more? What is the recall rate? I know that some people think recall rate is the coverage rate is different. So could you please explain that?
I had a suspicion you're going to ask a very difficult question. Now, false positive rate is the need to take action upon that first sample. That action could be, I want another sample. That's easily done. But if you have to recall the baby for further diagnostic testing, which then presents great concerns and anxiety in the parents, a pediatrician will have to talk to the parents of why their baby is being recalled, why their baby will need further diagnostic testing. And in order for a screening program to be effective, you want to keep that recall rate as low as possible. For instance, any new program that starts, they will always be more cautious and may have a recall rate of 0.6, 0.8%. That is 0.6% of the population have been requested for another sample, or that a pediatrician had to intervene to see how the baby is doing. Right? That causes in the first period of time some difficulties for the pediatrician. They've probably never heard of 3-methylcrotonol-CoA carboxylase deficiency. And the other is that if you have to recall the baby for confirmatory urine organic acids, plasma amino acids, or even CSF, it's a significant. So ideally, you want to be below 0.2. Those programs who are very good can get it down to 0.1. So our interaction with you, Jamie, was to focus on ensuring that when you look at the profile, you understand the profile and only recall those babies in which you are going to have some action required.
Thank you for the answer. I think we okay to move on.
Comes to the interesting part. So now what I'm going to do is all that which I've given you as theory, we're going to put into practice. The examples I'm giving you are real clinical examples and what you need to be mindful of. So just to recap, clinical interpretation algorithms, profiling is necessary. You need to understand and become familiar with biochemical genetic pathways. You have to understand the concept of profiles. You need to apply the interpretation of amino acids and acyl carnitines measured by mass spectrometry with their respective reference interval to make a judgment on what you're going to do clinically. And you need to develop these interpretive tools. And one of them that is available on the internet is one out of the Mayo Clinic run by Piero Ronaldo, is the Collaborative Laboratory Interpretive Rule CLEAR. You can register to do that, and I'll give you an example of how that works. So here are case examples, right? Again, this is the acyl carnitine profile. You immediately see that they're grouped in according to their respective profile. The GA1, glutaric aciduria type 1, requires you to measure the marker metabolite, C5DC, glutarol carnitine, and these ratios. Column 13 is baby 13. Baby 13 has glutaric aciduria type 1. Baby 25, who has a profile of MCAD, that baby has medium chain acyl-CoA dehydrogenase deficiency. Baby 14, column 14, has VLCAD. And then the one here at baby 16 has potentially 3 or 4 different disorders. I'm just going to go through for you the example of MCAD. It's a simple example. The MCAD profile is represented by C6, C8, C10. So this profile tells you the likelihood of it being MCAD or not. We have the value. So for C6, we've got 0.51 micromoles per liter of whole blood. Its multiple of the median is 5. The reference interval is 0.05 to 0.2 for the 0.51. So we can look at this by using what's called 3D plots or MOM plots. Okay? This is a 3D plot of this index case that I've just provided you here. I've plotted in a 3D plot C8, the marker metabolite, C8, C10, a very strong ratio, as is C8 to C6. This blue box represents 98% of the population. Our index case is all the way out here, so it's very, very likely that it's got MCAD because it's away from all the others. We can now plot that by multiples of the median. So this gives us a profile in multiples of the median. C8 has 32 moms or 35 moms. C6, this is the red cake. The blue square represents the 99th centile for each of the respective analytes of the 99th centile. So that blue box is the 99th centile for C8 as a multiple of the median. So you can quickly see in this profile that this baby is likely to have MCAD, okay? Now, what happens? This is a real life case. This case of a baby, full term, unremarkable, newborn screening collected at 48 hours. But what is noted is the clinical information here that the baby is on dextrose and saline via central line. You don't know why. Obviously, the baby is hyperglycemic. So that rings bells, right? You've got to pay attention to that. So this is the profile. I've expanded it so that you can see clearly. So 2.75 kilos, 2 days, 16 hours, breastfed baby, 36 weeks gestation, unremarkable. Now, if you look at this, it doesn't look terribly abnormal. Okay, there's a hint that C8 is elevated in one of the ratios, then you might be tempted just to say maybe normal, false positive, or maybe ask for another sample. But if we plotted this baby's results on this 3D plot, the baby is sitting out here. The others are sitting all the way over here. And I'll tell you why these babies are here. But this baby is here, so already alarm bells. If I do the multiple of the median plot, it's not as exaggerated as the first case I presented. Okay, you can see the mom of C8 is elevated, but, it's not terribly alarming. If we then put it through what this website run by the Mayo Clinic, CLEAR, it plots the analytes for this and then plots a risk factor for this baby with this result. And this comes from their software. And so these are all a number of mine. This is all of Australia, not many. But these are thousands of MCADs that have been collected by the Mayo Clinic to generate this algorithm. It's given a score for this baby as 9. Less than 20 is normal. Yeah? Okay, you might be tempted to say normal. But what we did based on this and based on that, and given that the baby was on dextrose, we said, we want another sample. We want that sample very quickly. And that's the repeat sample at 6 days. When we did the genetics on it, that baby was homozygous for the G985. So you've got to be careful, interpret this information, not only based on the analytes and against your reference interval, but if they put the babies on dextrose, they put a lot of babies on dextrose. But on this case, the dextrose was masking the fatty acid oxidation defect. In being given dextrose, the baby doesn't have to beta oxidize. It's using the dextrose. It can mask. Now, okay, remember when I said back here that I had all these babies up here? You can say, well, why aren't they affected? They're not affected because their profiles was this. No ratios were elevated. You got CA, you got C10. You might be concerned. We're not concerned because this baby is just normal fasting state. Okay? If you were to use a discrete test, you might want to recall that baby thinking that it's MCAD. So this is the power of profiling, understanding the biochemical genetics pathways. So this baby, we did nothing because it's normal fasting pattern. It's doing what it should be doing, beta oxidizing. Okay? We got 36 MCADs in the last, I don't know, 15 years or so. And this is a 3D plot, C8, C8, C10, and this time it's C6. There's 154,500 unremarkable babies, all clustered down here. And these are the profiles of the 36 babies with MCAD. There's one missing there because it's so high. And you can see that the only one that sits outside of this algorithm is a baby who's only a carrier. Okay? This little red dot out here. We've, out of those 36, 35 diagnosed perfectly well. We had one baby with MCAD who died before we can get a result out. It was so catastrophic that the baby had died. Unfortunately, the baby was born on a Thursday. The sample collected on a Saturday. The lab didn't get it till Tuesday. The result wasn't available till Wednesday. And when notified to the metabolic clinic, the baby had died at home. Died at home as a result of having MCAD. Okay? All the other babies are doing extremely well, all asymptomatic. One might have had a metabolic crisis because they're an outer ear infection, but they were already identified as having MCAD. So whenever they had an immunization, they would be brought into the hospital, put on a drip, and then being given the immunization so they would not get catabolic. Right, here are some other cases. Glutaric aciduria type 1, VLCAD. Now this profile could be any one of propionic, methylmalonic, and cobalamin disorders. And so that could be associated with several disorders, such as acute encephalopathy, megaloblastic anemia, a whole host of different disorders. Recall that some of the analytes, particularly C3, have poor positive predictive value. So in this group, we have to use the measurement of other secondary metabolites. So these group of disorders fall into the category of intracellular metabolism of cobalamin. Okay? The defect could be anywhere there. The elevations of propanol carbonate is consistent with a number of disorders. The only two things we measure routinely is C3 carnitine and methionine, and they're at the far ends of their respective pathways. So what we need is the measurement of a second-tier compound called methylmalonic acid. Methylmalonic acid. And it's critical to be able to measure methylmalonic acid to distinguish between these disorders. And we do that by mass spectrometry. We go to the original blood spot, punch another spot, isocratic elution, and that method is being put yesterday by the application specialist on Jamie's 210 machine. I won't go into the details of how it's measured. It's very straightforward. It requires a column before the mass spec because the two compounds that you want to measure, methylmalonic and succinic acid, are isobaric. They have the same mass, the same charge. So if you don't have a column to separate them in time, you won't be able to distinguish them on the mass spec. And again, you measure the amount of methylmalonic acid by having the D3 stable isotope of methylmalonic acid. And the same way that I showed you how to measure phenylalanine, it's the ratio between those two, and it gives you a concentration of methylmalonic acid in that 3 millimeter blood spot in micromoles per liter of whole blood. And so this is how powerful it is. So this is 1,842 individual babies who had an elevated C3 carnitine and a low methionine. There's some green ones there because we put some normals in there to get a reference range. All of these 1,842 had the measurement of methylmalonic acid. So now the x-axis become methylmalonic acid, and you can see what's happened as a result of introducing the measurement of methylmalonic acid. We've teased away all of those, removing all the false positives, and only identified those conditions. So here we have a cobalamin D, we have a cobalamin A, and we have a number of babies who are B12 deficient. This also identified mothers, 2 mothers that had antibodies to intrinsic factor and through breastfeeding were not providing the necessary B12 to their baby. We had elevations of methylmalonic acid in the baby, but it's the mother who had the deficiency, and we identified 2 cases of intrinsic factor. The B12 deficiency in the mother because they're vegans and have a deficiency of B12. Now, you can see that there is a lot of false positives, but we removed them because we're measuring methylmalonic acid. Okay? I won't go into details. These are all the cases. And we picked up cobalamin A. There's the variants, cobalamin D and its variants. We quite a number of cases of B12, 4 cases of homocystinuria, 2 cases of maternal vitamin D. Right. Just to show you how powerful this system is, even when a baby declares itself clinically, this baby declared itself clinically. Fortunately enough, he was born in our hospital, and our metabolic clinician, Drago Bratkovic, was very quick and asked for a sample to be collected within 2 hours after birth, because the baby had severe lactic acid, hypoglycemia, very unresponsive. So Drago, astute as he was, said, this smells like an inborn error of metabolism, collected a sample only 2 hours after birth, and this is what we found. So this is a sample, not at 48 hours, but at 2 hours of age. It had a high elevation of C3, high elevation of C5OH. 2 different pathways were affected. So this has alerted us immediately. We knew what this was. This was affecting the biotin recycling process, where biotinidase is involved as a second tier, and the defect laid here, and it was a hollow carboxylase synthase deficiency. This baby responded perfectly after being given biotin. In actual fact, Drago suspected it and already gave the baby, after the sample was collected, biotin, in the suspicion that it thought it was a hollow carboxylase deficiency. So this is a result on a baby that was only 2 hours of age. So you can see the power of this. And it was homozygous for the common C647T, and so this is the genetics to follow. Now, I'm going to scare you by showing you fatty acid oxidation defect. And you'll have to memorize this, I'm sorry. But what I'm going to do, whilst this is very complex, you can break it down into sections. Each section will have its own profile. Okay? So don't be daunted by massive pathways when you can break it down. Right? So I'm going to show you, and this is breaking down. Okay? I'm going to give you a case presentation of VLCAD here, where it can't convert the C14 from C16 down. Right? Patient 14. I've expanded that to show you the elevation of the profile. Now, C14-1, if it's VLCAD, comes in position 5 and 9, C14-1, C14-2. If it comes from C14-1 with a delta 8, that's dietary. Okay? But this profile was highly suggestive of VLCAD. We proceeded with variant analysis and found this baby to have 1 pathogenic mutation and a VUS. So we weren't any better off. So what we had to do was cultured skin fibroblast to determine whether this was affected or not. So the predicted phenotypic variation with a VUS, we didn't know whether this baby was going to have into trouble and was just going to be benign or indeed have VLCAD. And so we undertook cultured skin fibroblast to do the flux assay for the ability of the cultured skin fibroblast to metabolize C16. And this baby was confirmed by cultured skin fibroblast flux assay to have VLCAD. So this baby had VLCAD, even though we identified simply a VUS along with a pathogenic mutation. It was only the additional phenotypic information that we got from the cultured skin fibroblast that we either confirm or exclude. Here's another fatty acid oxidation defect. I've expanded those that are elevated. So we got, in this case, an elevation of these fatty acids, carnitine, the hydroxylated ones, and the enormous elevation of these long-chain fatty acids. If we put in our profile by multiples of the median, you're seeing that this profile is not normal right across the values. This told us that the defect is in the first part of the fatty acid oxidation. It is, in actual fact, carnitine, acyl carnitine translocase. So this baby was identified by this profile as having CACT. Right? Now, the last two examples are those things which you would not expect to detect as an inborn error metabolism. These we picked up. So this now describes to you a profile in a 3D plot of tyrosine, methionine, and Fisher's quotient. Fisher's quotient is an old chemical pathology measurement of liver function. It's leucine isoleucine plus valine divided by tyrosine and phenylalanine. So we know the transient hypertyrosinemia of the newborn is very common. And these yellow ones that are really high are indeed those low birth weight preterm infants. There's 154,000 babies in this cohort. Most of them are encapsulated within this green parabola. Okay? We got two, well, we got baby one first, and then 2 years later we got baby two. Now, those two babies were full-term, normal babies. They weren't low birth weight preterm infants. They were unremarkable. You know what those babies had? Neonatal hemochromatosis. As a result of being able to identify them, because these babies should not have been there, we immediately rang for another sample. And it's upon those immediate recall of those samples and the additional follow-up, the liver enzymes and so forth, that they were identified as having neonatal hemochromatosis. They were chelated, antioxidant, and completely normal. The neonatologist wrote a nice letter to us. Had those babies, or the first baby, been out there for another week, it would have required a liver transplant. Now, this is the piece de resistance. In all of this that we've been doing for 30 years, are we doing more good than harm? Recall that I sent you that not all the screening centres commenced mass spectrometry at the same time. Us in Adelaide and in New South Wales commenced very early on, and the other three centres came on board 2 or 3 years later. Australia is a perfect place for epidemiologists. Nobody gets on, nobody gets off. Inborn errors of metabolism are only identified and confirmed in these 5 centres. Right? As such, it made it very easy for us to do it. So we undertook a big study over a period of 6 years. We followed these babies up to the age of 6, asking the question, because there was a team that went to all these hospitals. Each of the pediatric hospitals went through all the case notes, looked at all the admissions and everything. It took a long time. But at the end, what we found is that by use of mass spectrometry, we identified 15.2 babies per 100,000 with an inborn error metabolism. And despite the fact that the metabolic clinicians are very good in Australia, they only picked up half of them before the introduction of mass spectrometry. And we made it even tougher. We said we only want to know about those babies in group 2. These babies in group 2 were asymptomatic and were diagnosed at and after 5 days of age. If they declare themselves clinically, they've already declared themselves. Mass spectrometry is not going to add anything more. This group we focused on. And again, we found that to be highly prevalent of inborn errors of metabolism, even within that group. So in the unscreened, there were 1.5 million babies, and there was only half or just under 500,000 babies in the screened group. If we just focus on one single condition of MCAD, in the unscreened group, there were 35 cases of MCAD, 2.26 per 100,000. In the screen group from Adelaide and Sydney, 24, 5.4, double what we see. you may very well say that those that were identified at NCO and not identified in the early period were neonatal deaths. Okay? So at the end of the day, because this was a publication of at the age of 6 years, and we concluded that provides better outcome at age 6 years of age for all disorders combined, with fewer deaths, fewer clinically significant disability calculated on a population basis. So are we spending the public sector money in an appropriate way? The answer is yes. I'm going to stop there. If anybody's interested in research, I can talk there, but what I'm going to do is just close it off by saying, in summary, you need some level of algorithm to do these interpretations. You have to understand biochemical pathways, and as such, you need the tools. You can use these 3D plots, multiple and medium plots. The addition of using of the second tier assays on the same initial spot greatly enhances the positive predictive value. Organic acids, I gave the case of methylmalonic aciduria. You need the current instrumentation that you have is suitable in sensitivity and is able to also be used for second tier. But most importantly is the importance on the clinical interpretive tools and the use of DNA techniques and other second tier tests to improve. So our outcome is that for an abnormal acylcarnitine carnitine profile from the blood spot, we identify one baby that needs to be recalled for a metabolic screen in every 3,280 babies. Right? So it's MCAD, and so for amino acids, it's 1 in almost 6,000. So overall, 1 in 2,200 babies require a metabolic screen. Once they recalled, our positive predictive value is near 65%. Out of 3 babies that we recall for follow-up, 2 will be confirmed by urine organic acid, plasma amino acids, or DNA analysis. The third is usually a false positive and is usually a carrier. Do we pick them all up? No. We've missed cases of cobalamin CD. We've missed a baby with VLCAD. So it's a screening test. As such, you need to balance it in total.
Thank you very much for very challenging cases and also how you interpret it. And also, I think we understand that when we report the newborn screening, it should not become like metabolite that go up, that go down, but we need to conclude for the physician. So we need to understand how to interpret that. And also, I think 3 things that it's important is cutoff for reference range. So it could be the how you choose the cutoff, right? And second is the pathway. I think we have fun with the pathway. Yes. The third one, I think, is the not the interpretation, but it's the system that we need to collect the data and also call the patient come back. And I think I might not have any question right now, but anybody in the meeting have any question? ถามอะไรคะ
Any sample for analysis? We can select 95 or 95 for
How many samples that we use to
Thanks, Jim. In order to generate your cutoff, you need at least 3,000 samples. 3,000 samples enables you to make a good estimate of the first centile, the 99th, and 99.5th centile. It's a statistical derived numerical value. If you go less, you run the risk of having a wider change in those cutoffs. Right? 3,000.
And like you said, it need to specific the clinical information, the term, the birth weight. It could be more than 1.5 kilograms, and the age that the collect specimen, it should be like day 2 to day 5, not more than that, right? Yeah.
Correct, Jamie, for the reasons as low birth weight preterm infants are always a challenge. And the interpretation of those has to be dealt with on a one-to-one basis. But you need to ensure that the cohort on which you generated your reference intervals reside within babies who are greater than 1.5 kilos and whose samples being collected at 2 to 5 days for all the data that I've shown.
So when we're waiting for the questions, I have one question that you can explain. We deal with the preterm baby and also sick baby. And what do you do in the Australia?
Low birth weight preterm infants, we always collect the sample at 48 hours regardless. The interpretation of that is a challenge because the baby might be on TPN, it might have an other underlying condition, and we normally would collect up to 3 samples on that baby, right? And 2 samples, one collected usually at and always at 48 hours, because that can be very diagnostic, and another one around about 10 days of age. At 30 days or a discharge is optional. But yes, they need to be, because those babies are not going to go away, and they're usually in your hospital, and you can already see what tests they've been ordered. If they've ordered a pneumonia on a baby, you know that that baby's in trouble.
Any questions or anything that อาจารย์มีคำถามไหมคะ
I just learned from your lecture preterm base. We come to the lab and we look at the increasing of the number of the chemical and so on, and that make us difficult to interpret. Yeah.
It is a challenge. It is a challenge, and you notice that I didn't show any examples of that because they would have taken much too long. I thought that I covered the fundamentals, but the next phase for Jamie is to then focus on the low birth weight preterm infants and see what profile is associated with them, because they're on TPN, and so values go up. I mean, their ornithine goes up, their arginine goes up, because they're struggling with their urea cycle enzymes because they have immature livers, right? And so you will see elevations in a preterm low birth weight infant, and we've seen them as low as 550 grams. They're very small babies, and their functionality, and they're not going to go away. They're going to be there for a while. This is why we routinely collect more than 1 sample. We collect up to 3 because we monitor them, okay?
So I think you answer.
Problem with the transportation.
Okay. Yeah. Let me repeat the question. อาจารย์ Amonrat asked about Dr. Enzo, any problems about the sample delivered to the lab? No.
We monitor them, and my staff are diligent. We record in an audit if a hospital sends samples a week later, they get a naughty letter. And the naughty letter goes to the chief executive of the hospital, because it's imperative that we get the sample as soon after collected. What they tend to do is they collect several samples, put it all in one envelope, and send it all at once. No. They must send the sample as soon as it's dried, the criteria of collection, in an envelope or in a courier, and send it to us.
Yeah, that is very important point. I think Jan Chulalak asked about what is your recommendation about screening in a baby less than 1.5 kilogram. And she asked that should we wait until the weight reach 1.5 kilograms?
No. For the simple fact is that the baby could have an inborn error metabolism and easily detected. So the rule is always collect that sample at or near 48 hours regardless. The baby at 2 hours was collected for that reason.
And I already asked before this session to Dr. Enzo, the question is, when the baby is preterm and receive the TPN, so we see like a lot of amino acid or others very high. So how do we report in the official report?
You understand biochemical pathways, and given as I've just described, low birth weight preterm infants are usually have liver dysfunction, already liver immature, you get the elevation of the characteristic amino acids that you know. You know, if you get an elevation of ornithine, arginine, and so forth, it's because the urea cycle. So you would report, and you probably have information on the card that the baby's on TPN, but you would say, I would not report that because I know what that is. If I send back to the pediatrician that this baby's got an elevated ornithine arginine, he or she will have a cardiac.
Yes, I think so. So we report normal, but we can like note that because of the preterm multiple amino acid, or maybe we can like ignore that. Yes.
It depends what you feel comfortable about. You know, the more you tell them, the more they'll want to ask questions. So for you, you understand this is your report. Do they have to do anything about it? No. They know that it's on TPN. So if you're telling them it's on TPN, they'll say, ooh.
Yeah, I think so. Thank you for the answer. So Dr. Ponprot, he asks about what is your opinion for using exome sequencing for confirmation of the positive cases?
Yes. In other words, as I've given you the examples of the VLCAD, you can use exome sequencing for known pathogenic mutations to provide additional information. And it's important that it's, as I said in the beginning of the talk, it's the collective information that is required in order to confirm or diagnose these conditions. And we use exome all the time. It's easily done on the dried blood spot. We extract from the dried blood spot and we can do it from that if required. Now, you know very well that the future will be in those programs that consider that next-gen sequencing, whole genome sequencing, will be the answer to everything. But I don't think that's the case.
Thank you. So another question Dr. Julalak asks about, for carnitine uptake defect, most are asymptomatic. What is your recommendation for screening this condition?
The answer is you don't do anything because it's considered quite a benign condition. It depends on what you want to do. Now, you have found that this baby has a carnitine uptake deficiency. It might affect that baby later in life. So the onus is on you clinically to determine whether it's in the best interest to tell the parents that this baby has carnitine uptake, but nothing is necessary needed to be done. But I'm afraid the parents may not see it that way. So for us, we choose not to say anything.
For the screening, that if we see in the analyte that C0 is going down and other also are going down, maybe one thing that we concern is like maternal condition also, right? So I asked you last day about, do we need to collect the mom's blood?
Well, yes, a collection of the mother's blood also helps because we've identified conditions not in the baby but in the mother. One of the classical ones is the C5OH carnitine, hydroxyisovalerol carnitine. That hydroxylated C5 carnitine is passed to the baby through breast milk. And what happens is that the mothers can become severely, over time, carnitine deficient. We've picked up a number of maternal carnitine deficients where then a single dose of oral carnitine has made them feel much, much better. So, yes.
Okay. Any other questions from the floor? For the citrullinemia type 2 or like the citrulline deficiency that we may claim that we screen for that, but I think that we can miss many, right? So do you have any opinion for this?
No, as I said, this is a screening test, and even in the best hands, you're not going to pick up all the cases. Citrulline is a late onset condition, and as such, what are you going to do with the results at this moment in time in a newborn who's showed persistent levels of citrulline, and we've picked up 1 or 2 cases of citrulline deficiency, but we've only instigated measurement and follow-up at a later stage to make sure that it doesn't present any of the clinical signs. But you're not going to pick up all the cases of citrulline. You're not going to pick up all the cases of non-cotarded hyperglycemia. There's a lot of things. Ornithine transcarbamylase is another, but you're not going to pick them all up.
Yeah, that we need to understand that what we do and what that we can pick up and not pick up. So maybe we can like disclaim, like put the disclaimer or the education for the parents too. Okay, any other questions? So normally turnaround time from your labs, how many days?
We report 6 days a week. We run Monday through to Friday. The results on the mass spec that goes in on a Friday is interpreted on a Saturday, and action is taken on a Saturday. Believe it or not, a lot of inborn error metabolism happens on a Saturday. It's Murphy. He tends to dictate things, and we've had severe cases of an inborn error metabolism where they had to deal with it. So we turn these around pretty quickly. Upon receiving samples today, they're on the machine that night. The following morning, we're able to do the interpretation and take action immediately. If you have a suspicion, that is, a neonatologist or pediatrician says, I've got a very floppy baby, we can remote in by VPN and look at those results and report them at any time.
And you usually do like repeat the sample from the same blood, same paper. If you find that any positive result at first, so what do you do next?
Well, the standard operating procedure within the department of laboratory is upon finding an elevation, you've got to repeat it now. Okay, I want to see that result before I go home, and I go home at 5:30. So as a result, when we see it in the morning, we got an elevation. That is immediately pulled out, repeated across the card, because sometimes we've identified formula on the card where the midwife has spilt milk on the card. And so only one end of it is affected, and we tend to measure one spot, and then on the other 4th spot, we go as far away as possible. And if that confirms, we'll see that result immediately. The report's already written.
One more questions. How long that we need to collect the dry blood spot in our lab? And how collect the dry blood spot?
Do you want to keep the spot? Right. Well, again, in Australia, we keep the spots in our department indefinitely. We've got, I don't know, almost 1 million cards in storage. Other states, like Western Australia, only stores them for 2 years and then disposes of them. It depends what you want to do with them. Now, some of the analytes that you measure, particularly the acyl carnitines, the hydroxylated or the they don't last in the spot for very long. Within a few months, even if you put them in a freezer, they go off. But what doesn't go off is the DNA. So our policy is to store them indefinitely. It's just a policy we have. But if you want to use it for amino acids, lipids, and other things, It's very stable on the card, but some other things are not.
And how you collect in the freeze or
No, we have a off-site storage facility that's kept at below 10 degrees, right? So we don't freeze them. We don't do it because it's expensive to store them that way. So we have an off-site facility, secure off-site facility, which is a government-approved facility, and we have big plastic boxes, and we have about 3 months of those. They're all labelled, each and every card of a baby. In the screening software, we know exactly what box it's in. So if we need to recall it for DNA studies or something, then we can recall from this off-site facility, which is a courier, door to door. We sign off on it because these are samples that we are custodians of. We're responsible for it, and as such, we must ensure privacy and confidentiality.
Yeah, that's the concern. So one more questions about one of the metabolic disorder called biotinidase deficiency. So it's not the screening for that enzyme, exactly that enzyme for our program. Do you think that we need to do the biotinidase deficiency from the MSMS?
Well, you can pick up biotinidase by the elevation of the markers of propionyl carnitine and C5OH. But if you want to screen for biotinidase deficiency, then there is instrumentation to measure biotinidase activity, and that would be the easiest and quickest way. It depends. The prevalence of biotinidase in our population is so low that, if we were going to do it because we were recommended by the federal government to do so, I would do it on one of the automated machines and just measure enzyme activity. Cheap, easy, and quick to do. But there's problems measuring enzyme activity because you get low pseudo-activities and you identify those who may develop a condition a bit later in life. So measuring enzyme activity is always a bit more difficult than measuring a metabolite.
So that's means that we can detect the biotinidase from the C3 and then just C5OH and look at that. Yep.
Suggest you go look at your pathway.
Right. Yeah, the pathway that the biotinidase, the C3 and C5OH can going on. Okay. Any other question? Good. Not right now. Any adding comment, Dr. Enzo?
Only that you're doing rather well. Next.
Okay. I think we have time because just only 3 o'clock. We have very speed up. So, but I think if we can have, someone asking, which substrate in dry blood spot can easily degradation?
Right. If you restrict those to the amino acids and acyl carnitines, in the acyl carnitines, anything that is dicarboxylic acid, C5DC, C3DC, go off very quickly. We've been able to make a diagnosis on a sample that had been stored for more than 14 years. We retrieved that card from storage because at the time we were not screening. We were able to retrieve that card on that baby and make a diagnosis of multiple acyl CoA dehydrogenase deficiency because those metabolites were still present in that card. Now, there are things that are very labile. Succinyl acetone is another one that goes off for tyrosinemia type 1. The dicarboxylic acyl carnitines, arginose succinic acid. So some of these are very labile and you will not be able to measure it. But by and large, the measurement of the amino acids, very stable, and the number of the acyl carnitines, very stable. And believe it or not, we've been running a project for peroxisomal disorders where we're measuring lipids. Lipids are also very stable on the dried filter paper.
Okay. Dr. Tulak asked about the treatment. I think that she asked about, okay. It's a case of elevated. Oh, okay. Another case. So this is another case. She asked that there is a case of elevated tyrosine about 500 that I have followed until 8 months without any symptom. And succinyl acetone, right? It's negative. Should the baby receive the treatment?
No. Well, I mean, you've excluded the most critical of the conditions by tyrosinemia type 1. Yeah. But type 2, type 3, if it's got a persistent tyrosine at 9 months of age, then you're going to be thinking that it's type 2 or type 3. But you've excluded the most important tyrosinemia type 1, where you need to undertake clinical action pretty closely. So treatment for the other two conditions is dependent upon the severity.
Okay. Any questions? I think this is a very good start for us. I think this is our first educational session together with all the newborn screening centers, and a lot of people comes and would like to know more about this because we just started and we just would like to make it better. So don't think that I have any question right now. Do you have any? Nope, right now. No.
I think I've said I didn't touch much on quality assurance, but I could do that as well. But quality assurance is a clinical chemistry, clinical laboratory activity, and newborn screening is not special. It will need to undertake both in-house QCs that usually can come with the kit or make your own in-house, but it's imperative that you participate in quality assurance program because you're part of the ERNDM for the urine metabolic screens, and equally the Centre for Disease Control, CDC, provides you blood spots to which they have been spiked, and you need to report them. There is a proficiency one that monitors your ability to measure these, and given that you yourselves are using a particular kit, then you can go to your method-specific kit in order to ensure that you are following quality assurance. We're needing to be compliant. Our accreditation is pensioned upon the fact that we're participating in these, and when assessor comes around to do the accreditation, we have to show all our QAP compliance. It's mandatory. And it's no different like the clinical chemistry.
Thank you for that. That's a concern about the quality assurance. I have a challenging question for you that you can share us. How do you do when the machine broken?
Panic. But we have safeguards because we got 3 or 4 machines. You can't, because believe it or not, babies get born every day, and there seems to be more on public holidays than not. So yes, you need to have, one of the things that I said in weakness was ensuring that you're able to provide this service continuously. And so we have redundancy. In the event that we get hit by a meteor and our whole department goes, we have contingency plan under a memorandum of understanding to send our specimens to another state. Okay? So we are assured of continuity of service. So we have business as usual plans in place. But given that we've got several machines, each of those has a reference range for that machine, and we can swap and change between machines.
I think we have each newborn screening center, we have just only one machine. So before did we frustrate with that too? So Dr. Kunthon, Ajahn Julalak, Ajahn Nitiwa, I think we discussed about that when the machine broken, so we can just share to another site that we are welcome to use. I think we help each other too. Any other question คะไม่มีนะคะน่าจะไม่มีค่ะ so Dr. Enzo, I may have some presentation that maybe, yep, we changed. Thank you. Actually, it's not presentation, it's just the not a conclusion, but some question that we can see that we ask. Let's see that any question didn't already is in Thai, but I so when they register, I ask that any expectation and also the question. So let's see that anything that we didn't mention to. Any problem, any pitfall, or any concern you think that is the most concern or pitfall during your working, like 30-year experience? Any concern or any common pitfall that you can share?
All that it is, it's unforgiving, simply because you have to have redundancy in what you do, both in those who are able to clinically interpret. So you must ensure that you divulge that information to all the staff so that they're equally able to bring to your attention when something goes wrong. But what's imperative is to ensure that the machine is operating perfectly, because if they provide you with numbers and the machine is not working well, and then you try to interpret something for which the analytical problems it just won't work. But mass spectrometry is not going to go away. I was going to talk briefly, maybe at another time, the large research grant we've received from the federal government that's going to expand the screening, where we'll be measuring thousands, not 100, but thousands of different metabolites. The issues that we've had that we've solved over a period of time, when we first started, we encountered the same sort of problem. Our recall rate was much higher than what we expected, and understanding that you're not going to pick up all the conditions and ensure that you provide the best quality service, and this must be done via quality control, quality assurance, and having adequately trained staff that meet accreditation.
Thank you very much for sharing. Any questions? Maybe not. I think you all cover all questions that we have. I think. Okay. I think we can finish earlier, like 30 minutes earlier. 20, okay. So ค่ะก็ขอบคุณทุกคนนะคะ May I speak in Thai ขอบคุณทุกคนนะคะคิดว่าน่าจะเป็นจุดเริ่มต้นที่ดีค่ะได้ฟังดร. Enzo นะคะก็คิดว่ามีหลายๆอย่างที่จริงๆเราก็มาช่วยกันทำได้นะคะแล้วก็แชร์กันทีหลังจากคาบนี้ก็ได้นะคะแล้วก็จะฝากทำประเมินค่ะแล้วก็เผื่อจะได้เป็นคอมมูนิตี้นะคะก็เห็นออสเตรเลียเขาก็จะมีคอมมูนิตี้ที่เป็นจริงๆมันก็ไม่ใช่เป็นคอมมิตตี้อะไรที่มันต้องเป็นฟอร์มอลค่ะก็คิดว่ามันคล้ายๆเป็นอะคาเดมิกทีมที่มาเรสกันเองก็ได้นะคะก็ฝากทุกท่านทำประเมินผลแล้วนะคะถ้าตอนนี้ไม่มีคำถามแล้วคิดว่าน่าจะสมควรแก่เวลาเราเลิกก่อนได้ ค่ะโอเคค่ะงั้นขอจบmeet the expert วันนี้นะคะ so we all thank you very much Dr. Enzo that we have very extensive the meeting ค่ะขอบคุณค่ะทุกคนอาจจะเจอกันใหม่นะคะขอฝากประเมินด้วยนะคะแล้วเผื่อเราจะได้มีการ interact หรือจัดหัวข้อบรรยายแบบนี้อีกนะคะ I see Dr. Kunthon are you still here he asked about how often to re-evaluate the cutoff I didn't see that the last question
answer that
you monitor the population by plotting the median value for each of the analytes. When that drifts, the median value is an extremely powerful measurement of your population, and we monitor that on every batch. So we compare the median value of today's batch of 200 samples against the median value of our reference range that we generated from 3,000. If that median value deviates by more than 10%, we know that there has been a drift in the population. Now, in good clinical chemistry practice, you should be made aware very quickly by your kit QCs or your QCs that you're starting to get a drift. They would equally apply, to which then you would say, this might be reflecting on our population. And there are many statistical packages that you can use to determine this. We use SPSS, MedCalc is another statistical package, and if you're part of a university role position, you can get these packages very easily. But there are methods, standard methods of monitoring your population that gives you an indication that you've drifted away from it, and then you need to reassess and do the reference interval. We probably change our reference intervals depending. If we've had a major change in the machine because of a major service, that invariably will change things, to which then we need to then generate these reference intervals again, and we need to do 3,000. We've gotten much better, that we have a very good indication around about 2,000 samples, but to safeguard against the estimates, 3,000 samples. So there are a number of parameters. The median of the population is a good way of monitoring it.
Okay, I think we close the meeting right now. So ขอบคุณมากเลยนะคะ อย่าลืมทำประเมินนะคะ จะได้เผื่อเขียนว่ามีหัวข้ออะไรที่อยากฟังแล้วเดี๋ยวเรามาลองเปลี่ยนแล้วก็แชร์ประสบการณ์กันอีกทีหนึ่งค่ะ ขอบคุณค่ะ ปิดแล้วนะคะ สวัสดีค่ะ